Hello, everyone, and welcome to our Cardiovascular Imaging Conference. It's a pleasure having you with us today. And I'm Dr. William Zoghbi. I'm the chair of cardiology here at Houston Methodist. And the early part of the year is we talk about methodology. We talk about how images are constructed in various imaging modalities. I know last week it was about nuclear cardiology with Dr. Memarian. And what I'd like to share with you is some of the principles of echocardiography and Doppler. This is very important for people getting into the field, for fellows, trainees, and an early career. And also it's an important reminder for us who've been in this field for some time to reconnect with the basics. And the reason for it is, it really is very important for you as an interpreter or performer of any of these imaging modalities to understand the physics behind it, how images are constructed, because it can also give you a stronger basis for interpretation, particularly when there are some artifacts or things that may be not real, if you will, from an imaging point of view, and they're because of reverberations or other things because of the principles of echocardiography and Doppler. So what I'd like to do in the next 50 minutes or so is to go over the principles of echocardiography and Doppler. This field has evolved so much over the years. It is really a family of techniques nowadays using the same principle of sending ultrasound and reflected ultrasound that will be processed and ask different questions, either the intensity of what is the reflected wave or maybe a frequency shift of that wave, and that's the principle of Doppler echocardiography. So yes, things have improved so much from A mode, M mode, 2D, 3D, and various Doppler techniques and some of the processing of this, which is strain and strain imaging and the addition of contrast. So what we're going to go through is rather quickly the principles of this. Ultrasound waves and properties are essential. What the wave on the left side here is, that's the wavelength that produces basically one cycle. The longer the wavelength, the lower the frequency is. And if you take a look at the properties of ultrasound in biological tissues, the speed is quite fast, actually, is 1,500 or so meters per second. And you need to know, obviously, in air, this doesn't travel well, so you have to have a biological tissue or fluid for it to go fast. Properties of reflection, refraction are similar to light, and we'll go through some of them here. So basically the ultrasound transducer has at the tip of it crystals. They are called piezoelectric crystals because if you excite them either mechanically or with electricity, they will deform. And with that deformation, after they stop deforming, they will emit a certain frequency, and that frequency can be modulated to be fast or short. And you send bursts of these wavelengths that will hit a certain surface, and the surface for our purposes is the heart and the valves of the heart, etc., etc. So when it hits the surface, some of it would be refracted, some of it would be reflected back at an angle, as you know very well. But none of these you will be able to detect with the ultrasound transducer. The only thing that's detected is that little tiny red that is less than 10% of what you've sent already. So it's a very tiny reflection back from the surface that you're basically detecting back in that ultrasound, and the signal is processed with that situation. Now the various names and modes that use ultrasound is one is the A mode or amplitude. So if we take this burst or packet of ultrasound that is sent, and these are This is a more reflectant as opposed to a less reflectant surface. And you look at A mode. I know you haven't even seen those anymore on the machines themselves, but this is the amplitude that you're going to get back with the more reflectant and the less reflectant one. And if you turn these 90 degrees towards you yourself, you're going to see a brighter reflectant from the more reflectant surface compared to the lesser one, and this is called B, or brightness mode. And this is actually the basis for most of the ultrasound that we see, because it's a brightness mode. And M mode is M is for motion. So basically, if there is no motion and there is a time sequence, if you will, or display on the M mode, if there is no motion, you're going to see a straight line. If you're going to see like a surface that goes up and down, that's what you're going to see on the M mode itself. It goes up and then further down. And you can think of a reflection of a valve or other things that may change. So this is your M mode of an aortic valve up here that opens and closes. The back is the left atrium, and if you stir the beam towards the mitral valve, you can see the opening of the anterior leaflet and then the posterior leaflet if you record it. When the valve is closed, there will be a straight line. And going through the ventricle itself, this is the right ventricle, septum, you can see the thickening in systole, the posterior wall, the same thing, and the various measurements from it. So this is basically an M mode determination of a cardiac structure and function. Now this is 2D, and as I mentioned to you before, 2D is really a conglomerate of brightness modes. So think of these scan lines that are going through the sector. Now for cardiac, we'd like to have a sector as opposed to a linear array when you look at the abdomen or carotids, if you will. That stations itself or positions itself between the ribs, so you can have at least a good 90-degree sector to take a look at the heart. Now these scan lines scan from throughout the sector and then come back, and you can have 160 of those scan lines. Notice also one thing, that they're not completely parallel. So further down in the image, they're going to be more spaced, and that will give you by itself a poorer resolution for you to be able to discriminate various dots. So the further away you are from a transducer, the lesser the resolution from a lateral point of view, because also of the spacing of these ultrasound beams. Yes, you can focus the beam electronically nowadays, but this is the genesis of your 2D picture. And things have certainly evolved over the years that the frequency, the frame rate is quite fast nowadays, more than 60, at times 120 frames per second, which gets you close to a real-time view of the heart and its motion during systole or diastole. A couple of points regarding resolution. This is pertaining to echocardiography per se. There is axial resolution and lateral resolution, and maybe in 3D a resolution between the various planes, which is azimuthal resolution. Now we talked a little bit about that the resolution also dependent. If you have high frequency ultrasound, these wavelengths are smaller, and you'll be able to discriminate 2 points better than if your frequency is lower, the wavelength is larger, and these 2 points may not be able to be discriminated. And the beauty is with ultrasound, I think our resolution is in millimeter, which is really a nice resolution. Now, for axial resolution, meaning that this is the resolution along the scan line per se, not discriminating in the lateral resolution, but along the axis of that ultrasound beam, and it is actually the best resolution that we have. If you compare that to the lateral resolution, I insinuated also that as you go further, the distance between these scan lines gets a little larger. Yes, you can focus the beam a bit, so you can differentiate 2 points, as opposed to here, for example, in the same the beam, you're not going to be able to differentiate that these are actually 2 different points. So these are important things for you to keep in mind. I'll give you an example of lateral resolution issues. When you measure the surface or the volume of a left atrium, which is very far down from the apical 4-chamber view, you're going to see a haziness in the border of the atrium, and some of it would reflect back into the left atrium per se, and that's part of the reason that left atrial volumes, the way we draw them, are smaller than those obtained by CT or MRI. Now, these are important instrument controls that you may have when you go to the machine itself. There's an overall gain, everything is increased. Time gain compensation, why? Because this time gain compensation is the distance basically from where the ultrasound sector is arising, where the transducer is, all the way down. And remember, these gains, distance is time, right? That's how you determine how far or how deep a certain structure is, because of the time that it took for this ultrasound beam to be reflected. Lateral gain compensation is along the lateral border, reject, compression. All these are post-processing, meaning this is the ultrasound beam that has come back to the transducer, has excited the piezoelectric crystals, and we're trying to understand that. But all these are post-processing. The only one that really changes the energy or the output power is the mechanical index. So that's the only one that increases, the energy that is sent from the transducer for these reflected ultrasound to come back to your transducer per se. And the mechanical index, or MI, is peak negative pressure divided by the frequency, the fundamental frequency. And we started thinking more about it and measuring it or paying attention to it because of contrast echocardiography. And this is the effect, if you will, on a tiny bubble of microbubble. This is a positive energy of the wave during that phase where it compresses this tiny microbubble. And in the negative pressure phase of that wave, it will expand it. So you know that if you have a very high mechanical index, these microbubbles will ultimately burst. And that's why for you to image in clinical sense, these microbubbles, we have to use a lower mechanical index so not to destroy the bubbles. Other things that you may see is reverberations and attenuation. Interestingly enough, this is a mechanical valve here, and you have a thrombus on it, on top of it. This is from a transesophageal echocardiogram. And you have to think also of the ultrasound itself. What are the properties if the surface is very dense and very reflectant of ultrasound, so that the ultrasound comes in, most of it is reflected back, very little traverses beyond it, so therefore you're not going to be able to see it back again, and what you're going to see is mostly, blackness or shadow, meaning that I'm not able to penetrate even further beyond this, either calcium or mechanical property or any other properties that would inhibit further propagation of the ultrasound beam, as opposed to where you have fluid, like blood here. It traverses very nicely, unhindered, all the way till it hits a certain structure. Interestingly enough, there are some structures that will give you reverberations, like an oscillation, if you will, of these, and you're going to see that at times in certain normal structures of calcifications, but most often in mechanical valves, and you're going to see this. This is not shadowing, this is reverberation of the actual structure of the mechanical prosthesis. Now, is this thrombus or artifact? And you could see here that there is a certain echo density, if you will, and how do you differentiate that? Is this an artifact? And the artifact could be because of oscillation of the ultrasound comes back and hits the apex of this heart, goes back to the casing of the ultrasound transducer, comes back and forth, and you may see some reverberations here. And the question is this real, or is this a mass or an artifact? Few things that you could do. One, change the position of the ultrasound transducer. Two, meaning that you could do a short axis of that apex, if you will, a long axis of the apex as opposed to apical views. You could change the frequency, because some of these artifacts may decrease with the frequency, or change transducer altogether, or use contrast in those situations. And that's what detected in this individual here. You could see actually a true thrombus in this situation as opposed to just an artifact. Technologies has evolved. If you've been in the field for many, many years, it really is amazing how much, from a technological point of view, how much advancement there has been. Before the year 2000 or so, there were no fully digital systems, and high frame rates we were kind of struggling with. Things have improved from a processing point of view. Image quality is certainly much better nowadays. In the past, if you wanted to use a high frequency transducer, let's say of 5 megahertz, to have a better resolution of what you're looking at versus a 3.5 megahertz transducer, you had to change transducers. Nowadays, you could just dial in a change of that multi-frequency transducer. Harmonic imaging is about maybe 25 years now, and amazing actually applications of harmonic imaging. We did not have tissue Doppler 20 years ago or so. Speckle tracking, digital image storage. Nowadays everything is digital. Real-time 3D echo really have evolved. So over the past, I would say 25 years, amazing changes in technological advances, in image quality, in processing, in storage. So let's go through harmonic imaging. And it's very interesting that you would send a certain frequency, let's say a 3.5 megahertz, or let's say 3 megahertz frequency transducer. It emits a certain, it provides, you can have multiple of that frequency that is resonating from the structure that you're hitting. You could have sub-harmonic frequencies. And the interesting thing is that initially these were trying to be developed for better imaging of contrast material. But interestingly enough, that we found that even native structures like the myocardium actually can emit resonant frequency. So you would send a certain frequency and you listen at a at a multiple of it, usually a 2 times frequency. It provides image resolution, particularly in difficult patients, and allows better visualization of contrast. Now, if you take a look at bubbles themselves, these bubbles, they would resonate much more than the myocardium itself. So if I send a 2.5 megahertz frequency, these bubbles will emit 2.5 frequency, but also they will emit 5. So if I'm listening at a multiple of that initial frequency, I'm gonna see much more of what the bubbles are compared to the myocardium per se. And so I'm gonna show you some pictures of that. So notice also that some of the artifacts that we see with fundamental imaging, particularly in the apex, are significantly reduced when we use harmonic imaging. So this is, you can see the apex much better compared to this still image of the apex, where you couldn't see where the myocardium stops. This is an apical hypertroph, and now I can see the image itself. I can see where the cavity is on this heart. Now, if we use contrast, I think the major application, and that's what's FDA approved for contrast echocardiography, and we will have sessions on each one of these methodologies, if you will, is to enhance image quality. And it is very hard to understand where the heart not only stands, but what is the function of this heart in its fundamental look at the frequencies here. If you use contrast, and these are the second and third generation of contrast material goes through the pulmonary capillaries and goes to the left side, And this is where you could see much better. Certainly, it's almost like you put the light on of the heart function, the heart borders, the hypertrophy that there is in this heart. So there are multiple applications for contrast echocardiography. So I know I alluded to fundamental imaging versus harmonic imaging when you use contrast. Take a look at this. This is contrast used with fundamental imaging. Notice that I'm not seeing much differentiation between the contrast itself and the myocardium. It's really not enhancing much of my image delineation of the border. Now notice that if I just put this mode into harmonic, and there's an H there, into harmonic mode, the image from contrast per se is much brighter. I can understand also, and I can see much better the delineation between the cavity itself and the border. And you could relay these two. This is almost simultaneous by just flipping fundamental imaging into harmonic imaging. So one of the lessons for you, and I think nowadays all the imaging equipment is equipped with settings for contrast imaging, which uses harmonic the vast majority of the time. So that was imaging per se. So we sent packets of ultrasound. We know the reflection of that ultrasound. Calcium will be much brighter than blood, obviously, and myocardium. We know some of the issues that can happen with reverberations, attenuation with this. And the question that we're answering when you send the ultrasound beams, these packets of ultrasound, is how deep is it? Meaning how long did it take for the ultrasound to come back? And how bright is it? Differentiating different structures. So that's as simple as that from an imaging point of view. Now, Doppler asks a little different question from the same packet of waves that you've sent. And you know very well what the various modes, I guess, of Doppler is: pulse wave, spectral and color, and continuous wave Doppler. This is Salzburg in Austria, where actually Christian Doppler was born. It is really amazing what they were able to do back in the 1800s as to come up with the equation for the Doppler equation, which tells us about a frequency shift of the wave in relation to the movement of either the object itself or the detection of the object itself. And this was delineated, and the equation gotten from movement of the stars, believe it or not. So it really is amazing how you're able to do that. So basically, if you send this fundamental frequency and send it, and it's hitting a moving object, it's very interesting that if the moving object is coming towards you, the frequency shift will be much higher frequency. So therefore, the packets, the wavelength is actually smaller compared to what it was before. And if it is going away from you, the frequency will be lower and the wavelength would be longer. An example for this, for daily life, is if you're standing, let's say in Houston, out there and listening to either a train or an ambulance coming, you can close your eyes on that street and you could tell whether an ambulance is coming towards you or going away from you, because the frequency, if it is coming, it'll be higher and higher, 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 and then lower, 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 lower as it goes away from you. Interestingly enough, also in an application of the Doppler equation, if you're perpendicular, meaning if you're a little bit away from it and perpendicular to the trajectory of this moving object, you're going to hear the same frequency. It's not going to change. So if you're further away from the train and train is perpendicular to where you are, basically you're going to hear it basically the same. It's not going to change the tone or the frequency of that sound. And that's what you use here for an ultrasound, to use to try to detect spectral changes and velocity changes within the heart. So if this is the arch of the aorta, and if you ask how much of a frequency shift there is, it's going to be positive here and negative there, right? So it'll be positive and negative. Now, this is the Doppler equation, and the frequency of ultrasound is shifted proportionally to the velocity of the reflected target. So that's the frequency shift. I know your x-axis is not in frequency shift, but it's in velocity. To tell you the truth, early on, when we looked at aortic stenosis and other things, we looked the x-axis, the y-axis was frequency shift. So you had to kind of calculate what the velocity is. So this is the frequency shift, proportional to the velocity multiplied by 2 of the emitting transducer frequency. Notice cosine theta, meaning if theta is either 0 or 180 degrees, you're going to get cosine then is 1. So it is the maximal frequency that shift if you're parallel to, if the beam is parallel to the moving target, right? And if you're at 90 degrees, then cosine 90 is 0, and then you won't have any frequency shift. So daily life, we solve for the velocity, and basically you rearrange this equation so you know what the velocity is in relation to the frequency shift, and that's how the velocity scale is on your Doppler. So it's important then to think of, if you're going to calculate the velocity of a certain object, to think of the angulation. So if the angle theta is usually more than 20 degrees from the sound itself, you're going to significantly start underestimating what the velocity is, right? So how do we do that? You don't see in daily life that that we change, the angulation to calculate velocity. What we try to do, because we don't know where the 3D dimensional vector of that velocity is, what we try to do is optimize our angulation, our acquisition of the images. Let's say pulse Doppler and the LV outflow tract, you use multiple windows from the apex to try to get the maximal velocity. Same thing that you do with a, let's say, tricuspid regurgitation jet or an aortic stenosis jet. You use multiple windows and use the highest velocity, which is the highest frequency shift, so that you don't underestimate the velocity, so that you decrease that angulation issue that you have with the flow of the ultrasound beam. Okay? So pulse Doppler, it's interesting. Pulse Doppler is actually, we send a little packet of ultrasound. We send this little packet of ultrasound, but we're not going to listen all the time because we're interested in the frequency shift, let's say, at this level. What we use is you send this packet, it travels, and we know the depth, and therefore we know the time when we're going to listen again. So we listen again when it comes back at that level, and we listen for the frequency shift that has occurred. So if we sent a 3.5 megahertz, if this is the transducer at 3.5 megahertz, we'll wait a little bit and listen to that frequency shift. Now, interestingly enough, you don't hear a 3.5 megahertz because it's in the ultrasound unaudible range, but the frequency shift, because of the velocities of red cells, usually are in the audible range. They are in kilohertz. Could be 3, 4, 5 kilohertz or so, and that's why you hear these changes, right? So if it is, since the flow is going in this direction, right, is going away from you, right? So you're going to see a negative shift of that velocity, and that's what you see here in pulse Doppler. So yes, this is not in frequency, this is in velocity. The Doppler equation has been solved, if you will, for you. And you could see that the velocity or frequency shift increases, and then decreases gradually over time till the end of ejection. Same thing that you could now look at, what is going on in the mitral inflow itself. Same principle. I send my little packet of ultrasound. I'll wait for it to come back, and I listen then again to not the intensity, but to the frequency shift, right? This is the different question that we've asked, and we looked for the frequency shift, and we have a frequency shift that is lower first, and it's coming towards me as opposed to going away from me, so it's positive. And you have a much, in this particular patient, much more accentuation of the frequency shift and flow towards, atrial contraction, in this individual, some diastolic dysfunction. There is a concept of aliasing, because remember, you're sending these in packets. There's a pulse repetition frequency. It must be at least 2 times the Doppler shift in order to correctly determine the polarity of the shift. If the PRF is less than 2 times, you're going to see in an opposite direction. Same thing. I don't know how many people are going to disco nowadays with the pandemic, but if you have a strobe light and you're seeing people dancing, at times it's an illusion that you're seeing in there or moving in the wrong direction, because the frequency of you imaging is much less than for you to be able to see in that correct way of movement. Same thing, if you take a movie of a moving car, at times you see the wheels going in the opposite direction of where the car is going. Again, it's a relation of the speed of imaging in relation to the speed of actual wheels themselves. Okay, so that's the same phenomenon that we have here. So the thing is that we could improve on this by changing the baseline shift. So here we have some aliasing, and we could baseline shift it down to maximize it, and hopefully maybe gain twice of what that frequency shift could be and that velocity. Beyond that, you're going to see aliasing, and you're not going to be able to detect what the velocity is. A particular example is with pulse Doppler trying to interrogate a mitral regurgitation jet. Mitral regurgitation jet, as you know very well, is a very high velocity jet. And if I'm using pulse Doppler technology to be able to interrogate what this velocity is, that's what I'm going to get. Basically, it's wrapping around, and I'm going to see basically just a lot of spectral display here without me able to discern what the velocity is. Okay? So color Doppler is basically a different form of pulse Doppler. And instead of just having a tiny one area of a gate, you have a multi-gate approach to them. Now, the toll of this is that it takes time, and also it takes some accuracy and decrease in accuracy for you to be able to resolve all these tiny little multi-gates along the line of the color Doppler. For pulse Doppler, we use a fast Fourier transform analysis to get a really nice resolution of the equation of what these frequency shifts are. Here it's an autocorrelator, an estimation of the mean velocity by coding it also going away from you in blue, coming towards you in orange. Okay? So, and the frame rate would be lower, so you have to optimize the frame rate. Otherwise, you're not going to be able to see it well. You try to decrease, the sector, decrease the depth. So you try to optimize that, and usually you'd like for color Doppler, looking at flow, greater than 15 frames per second for you to be able to see something in real time. And we'll have certainly sessions for regurgitant jets of how do we use color Doppler technology to try to quantitate or semi-quantitate the severity of regurgitation. One thing that also it's important, differentiating aliasing from actually just a direction change. If you have a direction change of flow, or let's say with color Doppler, this coming towards you is going to be in the red zone, red-yellow zone. Here at the arch, you're perpendicular to flow. So actually you're going to have a black, so you have no frequency shift, and then it's become blue as it is going away from you. So your indicator for a change in direction of flow is actually this black mark in between colors of red versus colors of blue. Factors that influence color Doppler are gains, color map with or without variance, frame rate, and Nyquist limit, and we talked about that. And here, just a gain actually can increase quite a bit of what your regurgitation is for this aortic regurgitation. So the usual thing is, and actually there's really no automation for this. There are presets for certain gain of color Doppler before you start an examination on the machine. But actually the best is to increase the gain enough to have a little speckle in the background, and that tells you that you have optimized the gain for that particular individual. If people bring down the gain too much, you're going to underestimate what the color Doppler is for a particular jet or flow. Other thing is, if you decrease the Nyquist limit, notice here Nyquist limits of 21 versus 57, and best Nyquist limits is between 50 and 70. So if you decrease the Nyquist limit, you're going to overemphasize the very low velocities of blood flow. So you're going to see not only the regurgitation, but you're going to see any movement that is between 10, 20, and above centimeters per second. So you will fill the cavities with flow, as opposed to the right side here, where you see the regurgitation, because obviously it has a much higher velocity, and you don't want to overemphasize the very low velocities. So the recommendations from the society is between 50 and 70 cms per second for optimization of your Nyquist limit. Factors that influence the frame rate, and remember, for color Doppler we have to be mindful of that. Frequency of the transducer. The higher the frequency, the best the frame. Scan depth, right? Because if I'm scanning all the way down here, I have to wait for the ultrasound to go all the way down here and be reflected back. So the depth will slow down. Higher depth will slow down the frame rate. The width of the color region, right? So I would, if I'm looking for regurgitation, I'd like to keep it within the area of interest to assess what the color flow is, because if you widen this sector, also it's going to take much more time for you to process this to come back again, so it will decrease your frame rate. Line density, we don't change as that much, but for each one of the scan lines that goes down, it's not only one scan line. Usually it has a certain density, meaning we do it 3, 4, or 5, or 6 times before you move to the second scan line, for you to improve your accuracy of your determination of the direction as well as the flow. Pulse repetition frequency, I'm not going to go too much of that, is here. When we didn't have really CW, you could try to fool the system by saying that this is the area of interest. So I can increase my pulse repetition frequency here, but at the same time, since these are gates, I will be able to detect not only this one, but this, and this, and this, and this, and this velocity in the spectral display that I'm going to see, down the line. Continuous wave Doppler is very important, because here we're not sending packets. It is continuous sending of these frequencies, and at the same time continuous recording back of what is reflected. And since it is continuous, we don't have range gating, so I'm not gating to a particular depth, right? I may focus the beam there, but I'm not listening only to that particular depth. I'm listening all across, the line of scan. So let's say this is an aortic stenosis here, but the reason why I'm seeing this aortic stenosis high velocity jet is that along the line of this Doppler beam, the highest velocity is at the aortic stenosis. Notice there are some lower velocities, and usually these are in the alveolar flow tract. However, if you had a stenosis here, and this was mild aortic stenosis, and if you had a dynamic stenosis here somewhere in the ventricle, the maximum would be that highest velocity. So remember, by CW, you are interrogating all the velocities all across, and the highest would be wherever the highest velocity is all across it. And at times it could be a surprise for you. And if you want to know where is it, then you switch to pulse Doppler. and map it around. That's what actually at times we do for hypertrophic cardiomyopathy, to see if the dynamic obstruction is occurring in the mid-ventricle, or is it occurring in the LV outflow tract, or is there a combined lesion? Because if you have combined lesions, it will be very difficult to differentiate this combined lesions of dynamic obstruction versus fixed obstruction. Tissue Doppler imaging, relatively new. I wouldn't say new anymore, because it's been in existence of close to 20 years now. And in the past, we preferred not to take a look at Doppler of the myocardium per se, but the properties nowadays of the intrinsic properties of the myocardium, and the importance is really certainly has shined very nicely as to looking at what the properties in systole as well as in diastole. So this is tissue Doppler imaging at the annulus. You could see, the positive in systole, the heart is, coming down towards the apex. There is apical descent. So the velocities in the myocardium are positive, and this is during relaxation, E prime, if you will, and A prime. Speckle tracking imaging, really a very nice advancement. Again, nothing new, I would say 15, 20 years ago, with its applications for strain and strain rate imaging. Basically, these tiny speckles that are reflected back are tracked electronically, so you could assign, if you will, or track a certain speckle as to what happened to it from during the cardiac cycle of its motion. And the applications of these are in strain, which is deformation of the heart, right? In the past, we could only do strain or deformation of the ventricle in short axis view. We could send an M mode and look at thickening of the myocardium and look at deformation of the ventricle itself from diastole to systole. Nowadays, since we can track the myocardium irrespective of what window it is, we can look at this deformation. So let's take an example here. That deformation, this is L0, we started at 10 centimeters. And if the deformation is shrinking of this length, if you will, and remember, it is deformed not only in this direction, but also on the other, so it's getting fatter, but shorter, it's minus 20%. And if it is lengthened compared to the start by 20%, there's conservation of mass, so it becomes thinner, if you will, but at least if you measure in this direction, it is 20%, lengthening or 20% strain of that. And if there's no change, it's basically 0 degrees. So we look at strain nowadays, and you hear about GLS, which is global longitudinal strain. That's the most often that we use for myocardial function, to track it, to look at the regional changes, global changes, etc. We evolved from Doppler-derived strain, which is angle dependent, and this is angle independent. And I think the applications are really very important. Strain rate, something we would like to aim for. I don't think we're there yet because there's a lot of noise, but you could imagine, okay, take a look at a deformation. This is a slow strain rate. So the deformation, you know what the deformation is. This is the same deformation, but much faster. So the heart has thickened or thinned to the same extent, but the rate of change is different. This is the strain rate. At least theoretically and in animal models and some clinically, strain rate is very important from myocardial function point of view, as well as recovery of function, but we're not using it as much nowadays because of mostly noise. So we use predominantly strain, which is the actual change during the cardiac cycle. And there are 3 types of strain. Longitudinal, that's what we use the most. Circumferential, because the heart is also shrinking at the same time in its outside border, and radial, which is the vast majority. That's probably the earliest of radial strain that we've used with M mode shortening and thickening of the myocardium. And nowadays all that can be automated. Yes, you have to use your eye calibration just to make sure that the tracking is correct, but it's really beautiful because you could really follow the various regions of the heart, even at times layers of the heart, and end up with a global longitudinal strain that we will talk about from a prognostic point of view, from a quantitative point of view. And this is a bad heart situation here where ventricular function is really very poor and the global longitudinal strain is very depressed. Normally, usually it's above 18% or so for longitudinal strain. Depressed definitely below 16, and and the highest numbers usually about 25, or so percent. So we talked about digital storage. I think it's very important nowadays, and why? Because it allows you, instead of going back and forth, it allows you to take a look at the various acquisitions of this heart and see which ones are the views that you want to measure and how do you relate them together. It's very nice actually to have these displayed. Could be a 9-frame preview, if you will, and it's great because you can go throughout the heart and they'll come back and forth. Was not available many years ago, and it's great to be among us now. This is the standard. 3D, a great advance, particularly I think its implications at this stage of the game from the transthoracic point of view is ventricular volumes, regional function, and ejection fraction. I think these are going to be very important for us. This is just a reminder for me, and I left these in 2003. This is the beginning, so we are almost at 20 years, and the images were not bad to start with, and it's really amazing. So yes, this is the full cone, if you will, of 3D image, and you can cut through it and go all the way, and images have really improved so much since that time. It is very nice. The frame rate has improved so much in 3D volumes. So our sonographers are trained. Hopefully your sonographers are also trained in acquiring these images, and you can get not only 3D volumes, which are very important when you have a deformed ventricle with regional abnormalities. I think this is where we really need to push 3D from a volume and ejection fraction point of view, and you could do also regional strain. Look at these beautiful images of with transesophageal of the mitral valve. Color Doppler can also give you a 3D dimension of where these jets are. And the latest actually over the past few years, and different companies have these rendering which is almost having the pathology in front of your eyes. And you could see the flail leaflet here. This is transillumination technology from the 3D that you could really see very nicely. So what I did today is to go over through some of the evolution of the various techniques of echocardiography and Doppler. From the early days of Enge Edler, 1950s, of A mode to M mode, then 2D, then Doppler, color Doppler, transesophageal echocardiography, the use of contrast to enhance images, and we didn't talk about enhancing even Doppler, but we will talk about that when we address contrast. Tissue Doppler, and speckle tracking with live 3D. We didn't talk about handheld echoes, but basically has the same principles, and that's the beauty of ultrasound, is you can miniaturize it to take it to the bedside and put it in your pocket, so that it doesn't have to be office-based, could be anywhere really utilization. And the amazing thing to me is that all these technologies have been advancement in technology, transducer design, the piezoelectric crystals, the electronics of how do you handle the image, how do you process the image, improve it, filter it. But the principle is exactly the same, is sending a packet of ultrasound that is reflected by the structure, and you ask basically two different questions. At least that's what we've asked at this stage of the game. One, its intensity and how far it is to be able to localize it and get something regarding texture, etc., of the property of the myocardium or the structure. Two is, what happened to that frequency shift? What happened to that frequency that I sent? Did it shift because of a moving target. And we know in the heart, obviously, you have a lot of moving targets in it, be it valves, be it muscle, be it flow, and the applications of all this, because this is where Doppler, the Doppler principle is. And remember also the Doppler principle that it is angle dependent, so you want to make sure that you look at that. And the applications of speckle tracking, which uses some of these technologies, and it is not angle dependent, which is really wonderful. And I wanted to leave you, and I usually do that, I wanted to leave you with this video. This is from Dr. Inge Adler. He's from Sweden. He was at the University of Lund, Lund, and this is echo examination in 1960. So we're talking, a few years ago, and really amazing as to how much this technology has evolved over time. For our sonographers, this is the dress code at that time, and you may want to revert to it. It really depends what you wanted to do. This is Dr. Inge Adler himself, dipping the ultrasound in a little gel, and putting it on the chest, and you're going to see the beautiful A mode of ultrasound. And actually, that's what started, the ultrasound field. Just imagine the change of these images to the current images, which are almost like real time in front of you. And I say that to many individuals is the beauty of echocardiography is that you could almost see anything that you're really interested in: structure, function, systolic function, diastolic function. The only thing that we're really not seeing is the coronaries themselves. So it is an amazing technology that can be used at rest, during exertion, during intervention, can be repeated without radiation, and very cost effective. So I would request and push from you that for you not only to know the basics, but whenever you see an ultrasound, an echocardiogram in front of you, use as much of the information that you have, because it can be quantitative, qualitative at the same time, and very comprehensive in your diagnostics as well as your management of patients. So thank you very much for your attention. Hopefully that you've enjoyed it and went back to some of the basics with me today. We'll take any questions. You can send your questions and text them, or from the conference room, I'll be happy to answer any questions that you may have. All right. I think we're okay. That's a wrap. Thank you very much.